there's others in your organization that are unable to attend, these will be posted here at the HVHCSafety.org site, as well as the High Value Healthcare Collaborative Dissemination member site. So I think we just lost our slides, but
Just keep going.
anyway, so as far as housekeeping goes, if those on that have called in, if you wouldn't mind muting your phone during the presentation so we don't get any feedback. There will be opportunities at the end of the presentation for Q&A, and we hope to have a nice lively discussion. But another option for questions is you can put them in the chat box, and we'll be monitoring the chat box here, and we'll bring those questions up toward the end of the presentations. So without any further delay, I'll go ahead and turn it over to Andreas with any quick updates.
So welcome everybody to the Patient Safety Sepsis webinar that we're doing on a quarterly basis. This is actually the second installment this year that we're doing it. And I won't spend much time on project updates because we have a meeting coming up in DC where you're going to be all updated on everything that's going on. I just want to focus on the webinars themselves as we're doing it. The topics of these webinars are identified by site visits and by other communications that we have with you. And we started in January with Terry Clemmer from Intermountain. Intermountain has a very mature sepsis program, and he gave an overview of that program, along with Shelley Sanders from Providence, that has a relatively new sepsis program. It was very interesting to hear about the many parallels that they've had, many common issues and commonalities as well in terms of overcoming them. And for today's webinar, what we have identified as something that many people have great interest in is nurse-driven initiated protocols for our patients with sepsis. And many of our sites have done some great work around that, but today we want to highlight two really outstanding efforts from Virginia Mason as well as from Wilcox Memorial that is part of Hawaii Pacific Health. So I'm really pleased to have those two sites present. Also, just pointing out that this is a truly collaborative effort. So we have 4 presentations from 4 different member sites. And we hope to continue that diversity of sites and efforts in the future. And we hope that if we approach you and ask you to present what you do, that you would be agreeable to that. So without wasting any more time here from my side, I'll ask the team from Virginia Mason to present their initiative around the Power Hour.
No.
Great. Can you hear me?
Yes, we can.
Great. Hi. Good afternoon. My name is Kristen Gordonier, and I am an inpatient nursing director, and I also have with me our sepsis project coordinator, Alice Ferguson. So, hi everyone. We'll get started. So in 2012, Virginia Mason began our sort of sepsis journey, and we began that work in the emergency department, where a lot of people begin their emergency department or begin their sepsis work. And one of the things that we wanted to do right from the get-go was to really simplify sepsis for people. So really break it down, just kind of like you would think of treating an MI or anything like that, where you can, there's very certain particular components. We wanted to make that visual and make it kind of stick with people. So we put this on everyone's badge cards or badges. We had this on posters. We taught this. So people kind of see this at Virginia Mason and they think sepsis. And so we did some things earlier on that really also kept it simple, things like having a 2-liter normal saline bolus rather than saying 30 mils per kilogram, for example, things like that to really just keep it simple. And our executive leaders who were leading this work actually from the very beginning at our organization challenged us to, if 3 hours were good, 1 hour might be better, and so they really wanted us to be able to get that bundle completely initiated in less than 1 hour, and that was their challenge. It definitely seemed impossible at the time, but the emergency department has been doing this work now for a number of years, and they continue to see amazing results in terms of how quickly they are able to activate their code sepsis bundle. Oh, they advanced. Next slide. Okay, sorry, I'm not sure. So just very briefly, the way that we use our Virginia Mason production system, which is a lean methodology to do this organizational-led work, and those things include things like our order sets, checklists, visual controls, things like that, to achieve that in the emergency department. Next slide. Next slide. Hello? Hello? Oh.
It looks like we've got a communication glitch. It's not advancing.
Uh-oh.
Let's see what we can do. Oh, there, we had a delay.
Is that the next? Okay, perfect. So, so then in 2014, our executive leadership said, well, that went really well in the emergency department. Now let's move that out to the inpatient setting. And we, sorry, that slide's got a little error in it, but we were very purposeful in our decision to move that to the inpatient setting because when we looked at who died of sepsis, and you see in this graph here that 3/4 of the patients who died of sepsis didn't have shock on presentation. And so those patients weren't going to the critical care unit, and so we felt that we could really impact mortality if we were to focus on early sepsis and actually focus outside of the critical care unit. So next slide. So then our executive said, okay, that's the right place, and we made sepsis an organizational goal at about that time, and they said, do the same thing that you were doing in the emergency department and do it in less than an hour on the inpatient unit, which really, if the ER sounded impossible, this just sounded like maybe a snowball's chance. So next slide. So we were up to the challenge, and we had a week-long workshop where it was actually led by our chief nursing officer, and it had a number of providers on the team from surgery and medicine. It had nursing leadership, nurses, folks from pharmacy, and we came up with something called the Sepsis Power Hour. And this is early recognition of treatment in the hospital. It's nurse-led. Next slide. And so this is a study that was done. It's a little bit old, but there is some precedence. There were others that were thinking about nurse-initiated protocols. And this was for treatment of hypotension, and looking at a standing order for a bolus on all kinds of shock. And we see here the time to completion for a nurse-led was cut in half, as well as time to MD arrival into less than half, and then decrease in mortality across all types of shock for this nurse-led protocol. Next slide. So this is the power hour. Really, this is the nuts and bolts of how it works. It's really about sorting the operators, doing the who are doing the work. So the RN, in less than 30 minutes, their work is to identify or suspect sepsis for a patient. They can put in an order for, it's a point of care lactate, order blood cultures, a white count if one hasn't been done, and they can start 500 cc's of fluid. The provider is notified that a power hour has started. They confirm sepsis with that information that the nurse is providing them. They start antibiotics as needed and complete that fluid bolus. pharmacy basically stops whatever they are working on, prioritizes those antibiotics, and hand delivers them to the patient's location. So that's how that works, and that's how we're able to get that accomplished in less than 1 hour on the unit. Next slide. So all of the power hours, the nurses and providers will receive feedback that when it's happened. This is an example of a recent power hour where we were able to provide antibiotics to a patient in 31 minutes, which was pretty amazing on an inpatient unit. So, next slide. I'm going to let Alice take over now as we discuss some of the results of this work that's been ongoing.
So this is Alice Ferguson. I'm the RN project manager for the sepsis work. So this is just some power hour data, and this just shows the lactate results for all of our power hours. So you can see about 75% of our patients, the lactate actually ends up being less than 2. And we were actually okay at our organization being catching a wider group of patients with the power hour. That makes us feel a little safer because then we know that we're not missing any patients. So many of these patients, if they didn't turn out to be septic, might have had dehydration or other clinical things going on needing attention. Next slide. So this is the really powerful part of our data. So you can see on the left side, here's our don't wait, initiate. This is our branding for our power hour. And the 85 patients, that's the number of patients since we went live in August of 2014 that we've caught on the inpatient units with new sepsis. So these are patients who started to look sick from the nurse's perspective. They called the power hour and then were identified to need antibiotics by the physician. So this is really our big success, is the effect on those patients. Next slide. And this is just some process metrics for our power hour. So you can see bolus and lactate there, and in the blue, that's our baseline before we started the power hour. And then in the green, you can see 86% of the time we're getting the bolus done within an hour, and 90% of the time we're getting the lactate. So this nurse-driven process is working really well as far as getting those two elements to the patient really quickly. Next slide. The other interesting part about our work is our rapid response calls. So the sepsis work partially evolved out of noticing, I think in 2011, that a large majority of rapid response calls were actually due to sepsis. And you can see our arrow is actually in the wrong place. I'm sorry about that. But in August of 2014, when we initiated Power Hour, we've also noticed a correlation and a decrease in the number of our power hours without an increase in our code blues outside the CCU. So that's just an interesting aspect that we've noticed in other data that we didn't necessarily expect. Next slide. And then this is our mortality. This is, I think, our favorite slide that just shows, as we've gone through our sepsis work through the ED and CCU and then on to the inpatient units, you can see our annual mortality has decreased. So we're super excited about that. Okay. Next slide.
No, that's it.
That's it. Yeah.
That's our presentation.
That's our stories.
Excellent. Thank you. I appreciate it. So if there are any burning or pressing questions or points of clarification, we'll take a quick break. And
Jason, this is Lydia from Intermountain.
Hi, Lydia.
Yeah, I have a question to Chris, right? So the sepsis mortality is applied to all sepsis patients, not only severe sepsis and septic shock you are presenting now. Is that right?
Yes, that's right. I don't know if you want to add anything, or Andrew? That's correct.
Okay, another question. Seems like there's more from your internal data collection. I don't know if your hospital have received any CMS report on the compliance. Do you guys see any discrepancies between two data collection process?
As far as the collection of the SEP-1 data?
Yeah.
And the power hour data. So
yeah.
I'm actually in close contact with our quality assurance analysis who's doing the SEP-1 bundle data. Mm-hmm. Unfortunately, the power hour and the SEP-1 Patient groups tend to be pretty different since the SEP-1 is
exactly.
really a CCU population, and this population out on the floor is really more inpatients.
Oh, okay.
It tends to be different denominators, different groups of patients.
Oh, I got it. And also time zero is so different.
Right.
Yeah.
Right.
Thank you,
And
guys.
time zero, we're calling for the power hour population. We're calling it at the moment that the nurse initiates the order set, which is the moment that he or she realizes that the patient is at risk for sepsis. They're showing SIRS and then that possibility of infection.
Yeah, this is really great strategy to have a nurse to start some certain medications. But we try to have the same thing at Intermountain, but it seems impossible. So it's great work. Thank you.
Thank you.
Thank you.
Great, thanks. Any other pressing questions? And again, we'll have hopefully plenty of time at the end to have a discussion. Okay, great. So let's go ahead and turn it over to our colleagues at Wilcox Memorial.
Hi, everybody. Can you hear me okay?
Yes.
Yeah.
Hi, I'm Dr. Amy Corliss. I'm the Medical Director of Patient Safety and Quality at Wilcox Hospital, and I'm here with 3 of my nursing colleagues extraordinaire at Wilcox who've really been the leaders in sepsis care here at our hospital. Dallin Johns is an emergency room nurse and emergency room manager, and he's been integral in creating many of the tools you'll see today. I've got Lori Pilkington, an operating room nurse who now is also in the quality department doing abstractions and actually doing concurrent review of all of these sepsis cases, along with her colleague, Alyssa Watson, who is now also a quality nurse, quality abstractor, but has a strong background in medical informatics, and particularly medical informatics in the emergency room. So this team really had all sorts of different angles to look at sepsis from. And just as a matter of background, I should tell you that sepsis has been a strong concern and focus of our care at Wilcox and at Hawaii Pacific Health for quite some time, not just since the core measure has come into existence. About a year ago, we formed our sepsis committee here at Wilcox in conjunction with a Hawaii Pacific Health-wide, our parent company, sepsis committee, looking at improving sepsis care. And we realized as the core measure was coming that we were going to need to really solidify some of the protocols and tools that we had developed and do a lot of education. And so that's really going to be the focus of our presentation today. One thing I think that makes us unique, at least in our facility and maybe amongst many hospitals, is that we do concurrent review of all of our sepsis cases, and actually started that before the core measure went live. So we were able to do deep dives into our successes and failures and really look to see what was going to be needed, what we'd have to change to achieve the results we wanted, and that's what we want to show you today. Next slide, please. So we kind of hope to take you on a tour along with the patient today, starting in the emergency room up through the inpatient ward or ICU, and talk about the different tools we have along the way, and then finally talk about what we do, like I said, concurrently to look at the patient's abstracting and quality and actually the interventions we can sometimes make in real time. So we'll talk about our emergency room screening tools today, which are in EPIC, our EMR. We'll talk about the worksheet that we have that facilitates transfer between the emergency room and the inpatient ward. We'll talk about our inpatient nurse screening tools, which helps to catch, just as our colleagues at Virginia Mason just talked about, patients who are up on the floor and going into sepsis. And we'll talk about some other tools that we have to educate our nurses and look at our quality nurse abstraction tool for concurrent review. And now I'm going to turn it over to Alyssa to talk about the ED component of it.
Perfect. Thank you. All right, so we knew that early recognition and early treatment was important for these sepsis patients. So we focused initially in the emergency room and specifically in triage. So next slide. Right away, we wanted to partner with our IT department so we can actually get tools in our EPIC system to help kind of guide our nurses in triage to identify these patients. So what we did, we actually created kind of a sepsis evaluation question in our system as well as an alert based on specific criteria. If you go to the next slide, I've got a screenshot. So we made it very easy. Evaluation for sepsis. We want this done on every single patient, and we're really just interested, is there signs and symptoms of an infection? So yes or no. If they select yes, kind of in our background, that all of a sudden kind of triggers a potential BPA. And if you go to our next slide, I can show you what it looks like. So we've got this patient may be septic ED nursing best practice advisory that's looking to see, yes, this patient may or may not have signs of infection, but it also needs to have 3 of the following, and that's basically our search criteria or a chief complaint of altered mental status. So if the patient meets this will fire right in the screen as soon as they're leaving triage, saying, hey, your patient may be septic. Let's notify the physician, and why don't we start, our screening standing orders. And so from here, if you go to our next slide, it'll open up our ED screening standing orders for our nursing care. Everything's pre-checked. So we've got our labs going, our lactates, blood cultures, and we also have our fluids added to this as well. Our fluids have been kind of an interesting journey. Initially we had our, that 30 mil per kilogram bolus added in here. We got some pushback from our physicians, especially with our CHF patients or end-stage renal failure, that, whoa, we don't want to throw a lot of fluids at them. So actually a recent change is we split this up. And initially we've got basically a 5 mil per kilogram bolus that the nurse can start right away, with the option of followed by that 25 milligram per kilogram bolus if the physician says, yes, we want that. But we've also asked for them to reassess that patient after every 500 mils. So this all happens right at triage. And now I'm going to have Dallin kind of talk about, additional tools on communication of getting these things done and up to the floor.
So next slide, please. So we started this campaign in the emergency room. And a funny story, the Sepsis 4 for Life was coined on a Friday evening before I was leaving work. My chief nurse called me and said, we need to work on our sepsis processes. This is in September, and I need something out now. Next slide, please. So here's our Wilcox ED Sepsis 4 for Life flyer. We wanted to highlight our 4 elements really to capture in the ER. Again, starting out with labs, followed with fluids, getting our 30 mils per kilo bolus ordered. Again, we have recently, as you saw in the order set, changed our initial nurse-driven protocol so that nursing and physicians feel more comfortable having fluids get initiated right away, and then the option to continue up, and that's from the nursing side. As you can see, with 3 getting our antibiotics ordered and started, we're not quite as cavalier and forward to get us down to 1 hour yet, but eventually I think that would be awesome. We're working on 2.5 hours of patient arrival to get the antibiotics on board. And then 4, as you can see, the hourly vital signs. And in parentheses, one of the areas that we've been working on, especially with our SEP-1, is making sure that once our fluids are completed, that we get the vital signs right away, 30 minutes post and an hour after, so we can really trend and see whether the patient has stabilized or if they need to move on to the next phase, if they need blood pressure medications. Again, with little notes down there for the MDs and the RNs, just to help them understand this whole process. Next slide, please. Here, let's see, that was in September, and then October we got a worksheet actually from our sister hospital, and then we revamped it. So this initial form was from our sister hospital and how they were communicating what needed to be done in ER and then what had been done in ER moving up to the floor. As you can see, we're capturing our areas, fluids, our cultures, and our lactic acid on this, and we also have the driving area to remind the nurses that once the fluids are completed, to get those vital signs after. We have it blown up there on the side that, again, if on repeat, we need to, if the blood pressure is not stabilized in less than 90, to make sure that we notify the physician immediately. And as you can see, for the receiving units, we were working on tracking to see where when these forms are filled out, we're asking them to return back to quality or myself for review so that we can continue our process of furthering education. Next slide, please. On the back side of this Sepsis 4 for Life worksheet, we also have the reference sheet. Our goal with this process was to help if nurses are in the process of treating a patient who they think may be septic, or if they have questions about sepsis, to kind of go through our SIRS criteria, sepsis criteria, severe sepsis criteria, and septic shock. It was really angled at the ER patients, because as you can see, there are some of the criteria that have blown or extended within the severe sepsis criteria and the septic shock criteria. We were trying to hit the main points. And it guides them through the general process that we're working on accomplishing with our patients that are presenting with sepsis in the ER, presenting very ill. Again, I want to point out that making sure that we're notifying our physicians after our fluid bolus is completed has been a big push here, and that it's been an integral part getting nursing and physicians at that point to work together so that we can continue on from our 3-hour bundle to our 6-hour bundle. And this is where I'm going to pass it back over to Dr. Corliss as far as what we've done to help the physicians in this process as well.
Great, thanks. Next slide, please. So we realized as part of the core measure that the documentation of the reassessment by the physician is obviously pretty crucial to pass the core measure, and it's also just good care, documenting what the patient looks like after the bolus is started and ultimately finished. So we developed this SMART phrase in EPIC, our electronic medical record, that helps to walk the physician through all of the different steps that need to be documented. We elected to leave the initial statement there, the patient re-examined at, as a wild card because, as we all know, doctors don't always do their notes immediately after they've seen a patient, and we wanted the time of the reassessment to be the actual time, not the note time. So here the doctor fills in the time they saw the patient. The vitals there is a SMART link that will pull in the most recent vitals, and we encourage our physicians to start this note at least as soon as they can to get those vitals at the time they reassess the patient. But that will pull in the most recent set of vitals. Then the heart and lung exams, again, are wild cards. They're free text because there's no prescribed required elements to those two types of parts of the exam. However, the next three are the places we ran into the most trouble. Sometimes a physician would document a reexamination but forget to do capillary refill, or it's just not something that they would normally document these days. So we have built specific SMART lists here to help them document what is most appropriate in these particular body systems. The next slide, please. So here, if you open up the SMART list for the pulses, it gives the appropriate named pulses and the appropriate description that would be necessary here, and that is necessary to pass the core measure. Next slide. Here we remind them to document capillary refill, although there's no specific required answer here. The assessment of capillary refill does need to be here. And then next slide. For skin, as I'm sure you all know, color is actually the most important thing, and it's something that's sometimes forgotten. We're good at documenting temperature and sometimes whether or not the patient's sweaty or what else is going on, but color is often forgotten. So we put in multiple different choices for color, including a wild card here, again, to help physicians document. And this was one way we were making sure that the continuity of care between the nursing care and the doctors continued. And I think what's really important is that reminder on the 4 for Life worksheet that instructs the nurse to call, particularly if the patient is still hypotensive and is in the septic shock category, so the doctors know to come and do this assessment. Okay, next slide. And moving on to the inpatient world.
Perfect, thank you. All right, so next slide. So inpatient nursing, so what we're going to talk about today here is actually for those patients who didn't come to the ER with signs and symptoms of sepsis, but actually those who developed signs and symptoms on the floor. We noticed, too, that this was an area where we could help nurses identify these patients. So once again, teamed up with our IT folks to create some tools. So we added that exact same question that we had in the triage, that, is there any current signs and symptoms of systemic infection? And we've added this to their shift assessment. So this is on the floors or in our ICU. And then we also have another best practice advisory that will fire. Again, it's looking at those SIRS criteria. This one also will look at their WBCs. And if they have 3 or more of those, this will fire. And basically, it's just alerting. Early screening for sepsis is met. Let's notify your physician. We decided not to initiate an order set at this time, just because every patient is different. They've all had different ordering in the past. So we really just wanted to make sure we have the physician notified so they can review the chart and see what needs to be done. There was a lot of education on the inpatient side as well, which I'll have Lori talk about now. If you could go to the next slide.
Good morning. We decided that all of our nurses needed to understand the importance of sepsis. We needed to discuss the morbidity, the mortality, the impact that it had on our length of stay, the whys of why it is important. So we did an education program, and initially in the summer we got 98% of all of our nurses through this program, and now we're at 100%. And every new employee also is required to have the sepsis education. And the sepsis education is important to explain the whys and also acknowledge the different triggers based upon our specific population, how we need to address our patients, what patients are most likely to have sepsis, what you need to look for. And then we provided tools with this little badge that helps our floor nurses have identification, early recognition, and then give them the tools that they needed to communicate effectively and efficiently with our physicians. So we created the criteria for the SIRS for severe sepsis, so that they could look at it at a glance, make sure, yes, they had all their information that they needed. And then on the back side of that, it gave them the tools to explain rapidly the situation. What is going on with the patient? What is the background of the patient? What is the nursing assessment of it? And then the most important thing was to request the blood cultures, the labs, the antibiotics, and the fluids so that we could effectively communicate with the physicians. Next slide, please. Okay. In addition to the nursing education, we developed an abstraction tool where we do concurrent review. We have the luxury of looking at every patient every day, and with this tool, you can go to the next slide, please. This is how we identify our patients that have severe sepsis, and we identify what treatments were in place and a timing event. We collect all this data. We can identify the appropriate first intervention, and we can relay the information back to the physicians and the staff to let them know immediately what worked well, what didn't work well, and what opportunities we have for improvement. We have also been able to do a deep dive because of this, because we're able to get immediate feedback not only back to the physicians and the nurses involved, but immediately we get that 360 feedback where they're able to tell us what was going on with the patient and identify opportunities, whether it's with our system, our IT system, was it a handoff communication issue, what exactly were the barriers that prevented the success of meeting the measures for this. So that's turned out to be a very useful tool, and it has allowed us to make a lot of very important, very small tweaks to our IT system, but very important in the success of our program. Mainly our lactic acid. The repeat lactic acid is probably our biggest success that we've had so far. And the more we dig, the more little tiny nuggets that we find that can impact the care and the resulting of the labs. With our IT program, we have multiple order sets and preference lists, and we've actually had to go into many physicians' preference lists and make the changes so that they understand that the repeat lactic acid is important for anything greater than 2. So this has been a very useful tool. And now I'm going to turn it over to Amy.
Okay. Next slide, please. So what we wanted to show is that all of this hard work has paid off. This is a graph showing our compliance with the SEP-1 core measure. And we were real lucky in October. I think we had done a lot of good advertising that it was coming and telling people what was going to be required, and everyone did a really great job right off the bat. And then we saw a little bit of sink in our compliance rate or our ability to comply with the core measure, let's put it that way. And as you heard Dallin talk about the changes we've made over the months, and Lori talk about the changes, and Alyssa, you can really see how the improvement in compliance with all of the 64, however many billions of measures it seems like there are, to be able to fully comply with that core measure. And although our February and March data are still preliminary, we're fairly confident they're going to stay around these levels, and our goal was to get above 80%. And as of March, at least as of now, we were striving to get above 80%. We're at one point obviously going to strive for 100, but we're pretty happy with being above 80% right now, and we're going to continue to improve. And I guess just in closing, I wanted to say that although there's so many people that are involved in the sepsis work going on here at Wilcox and at HVH, really at our hospital, these nurses you heard from today are really the champions of this. They have driven this from the beginning. They were preparing long before October, and every single tool you saw today was developed either exclusively by them or in conjunction with them, and they really deserve a lot of recognition for all the great work that's been done here. And that's all we have for today.
Wonderful. Thank you very much. So we'll go ahead and just open it up to the group for questions and general discussion for both our colleagues from Wilcox and Virginia Mason.
Hi, this is Isabel from Northwell. Izzy from Northwell.
Hi.
I was just wondering, I unfortunately am unable to open the attachments, but I've been listening intently to the presentations. When you say you educated all your nurses, how many nurses did you have to educate?
We're around 200 to 250.
Yeah, around the initial rollout was around, we're only a 71-bed hospital, so our nursing population, I believe, initially was 180 to 200, and now we're requiring every new nurse that comes through to get the education as well.
Does that happen on orientation?
It does happen on orientation now. We built it into their orientation for every new employee. It took us approximately 5 weeks to get all of our nurses for every shift educated, and that was done back in August and I think a little bit into September.
Excellent. Thank you.
Any other questions?
Well, Jason, if nobody has, I'll have comments and questions. This is Andreas Tanzer from the program office, and I'm the program lead for sepsis care at Dartmouth as well. I continue to be amazed by this awesome work you guys are all doing, and I'll be very frank in that we have been copying and lifting content from all of you guys over the last couple of years as we went along and improved our care. And as an example, we also have our own power hour like Virginia Mason, which actually turns out to have the same exact elements as well. And I have a question to them in a moment after I make my other comment. And I love the presentation from Hawaii, and as you were presenting, I actually lifted the 3 slides about the SEP-1 Smart phrase and mailed it off to our people and said we need to copy and implement this. So really hugely benefiting from this. For Virginia Mason, my question is, and this relates somewhat to SEP-1 and our struggles with it, is that your 2-liter bolus that you're initiating in many ways probably doesn't meet the 30 mL per kilogram requirements, at least not looking at the average weight of our population. And how do you deal and cope with those requirements in that setting of the power hour? And my question to Hawaii is, if I understand correctly, you have given nurses the privilege to start the entire 30 ml per kilogram bolus on these patients with a request to pretty rapidly get in touch with the physicians. Did I understand correctly? And if so, have you gotten some pushback for nursing to start the whole 30 ml bolus? Thank you.
So from Wilcox, if it's okay, we can answer this first. Yes, we did get a little bit of pushback initially to initiate the 30 ml per kilo bolus. There was hesitancy from both physicians and nursing to move the full 30 mils per kilo in straight away. Thus the reason for a switch to the 5 mils per kilo and the 25 mils per kilo, so that you had nursing being able to get it initiated, so we're able to start treatment right away, but at the same time have that safety net in there so that we can double check with our physician, and if the physician says no, we don't want to continue it, we can stop it after the 5 mils per kilo bolus. But if they identify the patient needs the septic treatment and we're going to continue down the sepsis pathway, then we can just go ahead and continue it on in that process. And it's designed for ease of use for both parties, both nursing and physicians in that way. One of the things that would have been a little bit difficult to see within the order set of fluids, there's actually a nursing communication that directs nursing to reassess the patient, breath sounds, lung sounds, and overall condition after every 500 mils has been infused. That way, if we're moving along that pathway of treating, say, our end-stage renal patient or our congestive heart failure patients, we can get that reassessment in there and stop it before we go too far. Those are the little things that we've done in this process to help physicians and nursing both be more comfortable with it.
And one other thing that I think has helped immensely here is that we're a small place and we have both physician and nursing champions for sepsis. And whenever one of these changes was proposed, knowing it was kind of earth-shattering and very different than the way we were doing things, the champions were very involved in creation of the new protocol, and then could disseminate it and really kind of speak to it out in real time with the boots on the ground people. And that really helped by these leaders being in support of these changes. It really helped the rest of the staff to accept and go with it, and just to kind of see how it was going to work.
Great, thank you.
Andreas, this is Andrew Cartoonan from Virginia Mason, and I know that Dr. Evan Coates wasn't able to make it today to today's webinar. With respect to your question about how we're reconciling 30 mils per kilogram with respect to kind of simplifying our standard of 2 liters of fluid, certainly there is a discrepancy in there. We're not, obviously, as you saw in our presentation, you're not seeing that a lot of our nurse-initiated protocols on patients are not meeting, those criteria that are within the denominator of the SEP-1 measure. The one thing I'll add is that I think in most cases where patients are in the shock category, we're leaving it up to physician judgment to initiate, an appropriate amount of fluids for patients that might be hypotensive. In that case, that might not be the answer you're looking for, but Evan's going to be at the conference in a couple weeks, and I'd encourage you to follow up with him.
Okay, thanks, Andrew. One of the reasons I asked is because we get dinged by SEP-1 measures for the fluid bolus because we are ordering a bolus, and CMS mandates that there's a rate associated with that. And so, when we have our nurses start the 500 ml bolus, it's always ordered as a bolus, so it doesn't count for fluids by CMS standards because there's no rate associated with that. And we struggle with that rate issue, to be quite frank.
And we got past that by actually building a rate into our order. So the orders that are on those order sets it'll say 5, whatever it is, that's 30 ml per kilogram, and that gets calculated out, but there's actually a rate built in to it.
And how do you automate that? Because if we do it, our pumps cannot do more than 999 mL.
That's what we have it set for.
Yeah. Yeah, but that rate more than meets the sepsis core measure.
I didn't catch that, how you get around the rate. So you have a built-in rate that's automated?
So in pre-populated into those orders in the order sets, the rate is 999 mil per hour, and that's an acceptable bolus rate by the sepsis score measure. It's more than 150 mil per hour.
Right, I understand that. So that requires, though, that the provider, whoever orders this, is using your dedicated sepsis order set. So if they go into Epic and just order some fluids as a bolus,
right,
then it doesn't meet that requirement, correct?
That is correct. That is correct. And that's been another huge piece of our educational push, is to really, at every single meeting, we are reminding people to use the order set. It's the easiest way to order everything you need. You don't forget anything, and you meet all the measures. I have to come talk to you about it later.
Yeah, it's interesting because once again, it's the same issues. We have the built-in rate for the order set, but people don't always use it, especially in the inpatient setting, where the patient already may be on antibiotics and some other things, so they just go to individual orders, and then we miss out on it.
Yeah.
Thank you. Very interesting to hear.
Any other comments or questions?
We just actually had one more comment to the last piece that Dallin wanted to add.
Oh, yeah.
So in regards to the physicians using just their freestanding orders, one of the things I think here at our facility that's been really helpful with that has been the concurrent review. So when those situations have come up, we've been able to get the feedback back to the physician right away and let them know that in the future to make sure to order that if they're going to order to put in the rate as well. Right. That way we can have both the education component and meet the core measures at the same time.
Right. And in some cases, if it's during business hours and we're actually here in the office, we've made the change on the spot and met the core measure because of Lori or Alyssa calling the physician and asking them to change.
Okay. May I ask a follow-up question to that? The concurrent review is filled out by the nurse, and then it's reviewed by somebody from the sepsis team. Is that correct?
Not quite, almost. This is Lori. We are in the quality department, and we wear multiple hats because we're a small facility. We also do CDI work. So we're in the charts every day, and we're reviewing every chart every day, and we are looking to see what was the first event of severe sepsis or septic shock. And we're the ones that are doing it, and we're relaying the information back to the nursing staff and to the physician.
Right. So the first point of review is actually the quality RN, not the bedside RN.
Gotcha, understand. Do you have a quality RN who even does that on the weekends?
Yes.
Yes, we do. We work on the weekends.
We have two, and they handle it all.
Sorry to hear. That's very impressive. I love the very short loop, reconnect, and improvement efforts, and the feedback that goes straight away to the people. That's very impressive. It's great work.
Thank you. This is Lydia. I have a question to Wilcox team. So on your slide, you're showing you're building the sepsis advisor for the physicians on the EPIC. Just try to determine time zero for the physician to document as soon as possible. So, so my question is, so when this advisor alarmed, so the physician can see from the EMR when they see the patients?
Yeah, so actually the one you saw was the nursing advisor. But we do have one for physicians that's actually even more complex.
The SMART, called SMART, right?
Yeah,
SMART.
Yeah. Okay. Well, the SMART, that was the SMART phrase for
SMART phrase.
There's basically a template for a very brief note. But right now, there's nothing. That is one little struggle we're having, and we're trying to figure out how best to address it. And again, we're probably going to turn back to our nursing colleagues. We have an idea to build a panel order whereby when the 30 mil per kilogram bolus is ordered, there's also a nursing communication order that's automatically attached to it that says please call the physician to reassess the patient when the bolus is complete.
Oh, okay. So
there's no good way for our EMR to alert a physician that a reassessment is required.
Okay.
Yeah, so we don't have an alert for that.
Yeah, because Intermountain right now really has a difficult time to determine time zero and also have a physician to document it.
Right. Well, one thing I would suggest, though, because I think it's a misconception about the core measure, is that you don't need to wait for the bolus to be entirely finished or for the first 3 hours to be gone by before the reassessment is done. It's really any time after initiation of the bolus for a septic shock patient, and remember, it's only for septic shock patients, right?
Right.
So what we've encouraged folks to do is build that part of the SMART phrase that may not be in their H&P into an H&P. So the reassessment piece, the ER physician assesses the patient, the hospitalist or the surgeon comes to admit, and if their H&P includes the required elements, then the reassessment's done.
Yeah,
Right?
I think for Intermountain, we're not struggling with the bolus. This is really the time zero. Right now, for frontline people, it's really hard for them to determine the time zero right now.
Yeah.
And it seems like all the treatment will going to be delayed.
Yeah.
And the compliance by this really strict CMS SEP-1 measure, it doesn't look good compared to our
We
internal.
struggled with that too. Across our entire system, at one point, they were using triage time.
Yeah.
Right?
Yeah.
Because it's the easiest thing to see. But unfortunately, if the patient develops septic shock at 6.5 hours, they've already failed.
Yes, exactly.
And where our concurrent review process is so crucial, because Alyssa and Lori can actually determine true time zero from the time that all of the measures are met, all of the components that make the patient fall into the measure are met, and that's what the core measure says.
Yes.
Time zero is. Yeah. But it's hard. It really takes someone trained in that to know when the time zero is, and the physicians complain about that all the time, not knowing how much time they have. And we just tell them, use your bolus as your guide. As soon as the bolus gets started, think about reassessing. And that's how we've taken it, because the bolus really needs to be started within 3 hours, right? So if they do it right after bolus, then they should be in the 6 hours.
Yeah, are you guys going to be at DC?
Are we going to be in DC? Well,
We haven't been invited, but we would love to, as long as it's warm there, because we don't have cold weather clothes.
Maybe someone can lend us some jackets.
Yeah, I think our team really wants to talk to you guys and learn from you guys.
Maybe you need to come here.
Yeah, there you go.
All right, thank you so much.
You're welcome. Thank you.
Andreas, one last comment. I can actually bring a full trash bag full of fleas if you want to DC. Kind of reconciling a little bit on what I've heard and a comment about the notification. We struggle with that time zero, obviously, as well. And one feature that Epic has that we use, and I wanted to hear if you guys are using it at all, is we have an inpatient sepsis sniffer that basically just takes a bunch of vital signs, and we are creating alerts if you enter the chart for the nurse or LNA as the vital signs are entered. But we also have attached a pager notification to that. So we have a sepsis surveillance nurse, and a page goes out to the nurse who's carrying that pager when a patient meets certain criteria based on vital signs in Epic to alert, that surveillance nurse to a patient who potentially is septic. And I'm just wondering, I'm not Epic smart enough, but if there could be timestamps built in, and there would be a way of notifying a resident on the primary care team, if you have residents, to do a repeat physical exam, that may be one way of doing that.
It's a good point. I'm honestly not 100% sure. We were just sitting here thinking that that's how our inpatient BPA, the advisory for both the nurses and the doctors, works exactly. Just like your sniffer tool, it looks at a constellation of that infection question and vital signs and labs and whatnot. So same thing. And we're going towards a fully integrated medical device system where we'll have the nurses will be carrying the Volt phones, and I'm thinking maybe that might be a way to do it. Right now, most of our physicians no longer carry pagers; they all do. But having a nurse dialed into the Volt phone with some kind of recommendation, or possibly even someday the physicians, it's a really great thought.
Great. Well, so two kind of final thoughts that I had. I'm sorry that Dr. Evan Coates is not on the call, because we heard, at Virginia Mason, when you had said you kind of put some branding around your initiative to "Don't Wait, Initiate" and the Power Hour. We heard that really strongly, and that Power Hour concept really stuck with Lucy and I when we were meeting with you and other colleagues there at Virginia Mason. So I think that point of branding is really important. So I want to commend you on those catchy phrases there. And then finally at Hawaii Pacific, a point that's been talked about a lot is kind of the tension with the SEP-1 measure and doing what's right for the patient versus doing what's right to meet the measure. And we heard very strongly with leadership support there from Dr. Melinda Ashton, and I think it resonated across the whole system how important it was to do the right thing based on your most appropriate clinical judgment. We're here to take care of the patients, and the measures, failing a measure, a CMS measure, can be dealt with later. So I wanted to commend them on that, and I see Dr. Ashton's on the phone. I won't ask you to comment unless you'd like, but that really resounded with us too. It was a message that we heard across the system, so congratulations on that. Any final comments or questions? Okay, so just another reminder again, we will have a recording of this webinar available on the website you see here. And if you have any follow-up comments or questions, or if we can connect you with individuals in any way, feel free to reach out to us at that admin@hvhcsafety.org, and we'll be sure to follow up on any emails we receive. So, final wrap-up, I just want to thank again Kristen, Alice from Virginia Mason, Amy, Elisa, Lori, and Dallin from Wilcox and Hawaii Pacific, and Andreas, our lead for this initiative. And if whoever's not going to be in DC, we hope to be in contact still, but also looking forward to see those that will be in DC in a couple of weeks. Thank you.
Thank you.
Thank you. I think.
Thank you all.